Welcome back. Our next speaker is Dr. Nassif Haddad. She's going to discuss personalized medicine and targeted therapies. Dr. Elise Nassif Haddad is from MD Anderson Cancer Center. She's a physician, scientist, and assistant professor in the Department of Sarcoma Medical Oncology with an adjunct position in the Department of Investigational Cancer Therapeutics. Her main research areas include leiomyosarcomas, undifferentiated pleomorphic sarcomas, immunotherapy, and drug development in sarcomas. Dr. Nassif Haddad, welcome to the exchange. We're so glad to have you here.
Thank you for having me. Thank you for the invitation. I'm going to try to share my slides. Hopefully it will work out. Okay. Can someone confirm you're seeing my slides correctly for me, please?
We're good.
Thank you. So thank you for organizing all this. I'm hoping that all the participants are finding this useful. Just looking at the program, this is a really big program to set up. So I hope everyone's realizing how much effort was put into this by the organizers here. So I have a somewhat difficult topic to tackle because it's a very scientifically heavy topic. I'm going to try to make it accessible, although I did also try to put in some scientific graphs for those of you who are actually interested in reading some of the scientific articles. So I'm going to talk about personalized medicine and targeted therapies. Those are my disclosures that aren't very relevant to the talk. So the outline of the talk is, first I'm going to talk about some general concepts, and then I'm going to use some specific examples of the targeted therapies and molecular testing that's done in sarcomas to kind of illustrate all of those general concepts. I am going to have at the top right, there's the number of the slides because I'll answer questions only at the end. So if you actually have a specific question on a specific slide, you can just note the number of the slide. It will make it easier for the Q&A at the end. So first we're going to start with some general concepts, and the first one is about personalized medicine. So the whole concept of precision oncology, which is a part of personalized medicine, is that at first when we see all our patients with their tumors, they all look very similar. It's just a big lump or a big bag of tumor cells. And what we do is we examine our patients clinically. We have some pathology, and I know Dr. Lazar talked to you about the pathology side of things yesterday. Some imaging review, looking at MRIs, PET scans, or CT scans. And then we do this thing that's called molecular testing, which I will be talking a bit more about in the next few minutes. And by doing all those things, then we start seeing in our patients that there are some differences in the type of tumors, and the type of patients, and their genetics, and their size, and we see a lot of more subtle differences. And the whole concept of precision oncology is that by doing that, by looking at all those little subtle differences in every patient and every tumor, we're able to find one specific drug for every specific patient or every specific subtype of patients by grouping them in very targeted specific subtypes of tumors, and therefore have something that's very precise in treating the tumor. So the whole concept is that for each subtype of tumor, we're going to have one drug. Now, when we look at what's the real life of this whole concept of precision oncology in sarcomas, is we're actually right now very, very good at looking at all those differences, at classifying our sarcomas in a lot of different subtypes. By now, with the whole 2 days of lectures that you've had, I think you probably know we have more than 100 subtypes of sarcomas, although we're talking about only 1% of tumor types. And that's because we've been very good at classifying and delineating subtle differences in our different types of sarcomas. Unfortunately, the reality of the treatment is that although we know that patients and tumors are very different and we're able to classify them and put them in pretty boxes, unfortunately, most patients get treated the same, and the most effective treatment we still have for the vast majority of our patients with sarcomas remains high-dose chemotherapy. And then we are starting to have some very small subtypes of cancers, subtypes of sarcomas, for which we actually have very good efficacy of immunotherapy or specific types of targeted therapies. I'll get a bit more deeply in those concepts. So what we call going from precision oncology, which is let's try to have one tumor, one drug for each subtype of tumor. And then personalized medicine is when we actually add to that the complexity of every patient, that because sarcoma is a disease that can affect patients from older ages to younger ages. All of those patients are actually going to have what we call comorbidities, which are basically other long-term conditions. So even though if we could attain the goal of precision oncology, meaning treating exactly the precise tumor with a precise drug, then we would still have to take into account that some of our patients have diabetes, have some cardiac diseases, and other diseases that make it a bit more complex to just find a tumor and give a drug. We have to treat our whole patient. And that's what personalized medicine adds, that extra layer of complexity, where sometimes we actually have a drug for a precise tumor type, but we do have to take into account all the toxicity of the drug based on the other long-term conditions that our patients have. So now I'm going to move into another type of general concept, which is molecular testing. So that's a very broad name. What usually we refer to when we're talking about molecular testing is genomic, so looking at the DNA and RNA. Now, that being said, molecular testing actually encompasses a bit more than just the DNA and the RNA. Sometimes it's looking at expression of certain proteins, which is another level of regulation. But in the vast majority of times when your physician is going to talk to you about molecular testing, what they mean is genomic testing. So basically, what is genomic testing? If you look at all your cells in your body, your normal cells and cancer cells, a normal cell has on average 22,000 genes. Out of those 22,000 genes, on average in all cancers, not just sarcomas, the cancer cell has 1,000 mutations, meaning that the cancer cells are actually cells that share initially the same DNA as the patient's healthy cells. But the difference between the healthy cells and the cancer cells is that out of the 22,000 genes, there are thousands of them that have some types of mutation. So sometimes of modification of the DNA. And that modification of the DNA can happen because of a variety of reasons. For some cancer types, we do know why. For melanoma, it's because of the UVs from the sun. In case of lung cancer, some subtype of lung cancers, it's going to be because of smoking. In the case of sarcomas, we don't have such evidence for most of our sarcomas that there's an environmental exposure causing those mutations. But basically, a cancer cell has 1,000 mutations. Out of all of those 1,000 mutations, only 2 to 7 of those mutations are actually really critical for the cancer cell to grow. So what differentiates a cancer cell from your normal cells is that it has accumulated those mutations, and out of those mutations, there are 2 to 7 genes that allow the initial cell that's initially similar to your own healthy cells to actually grow and grow despite any other regulation mechanism that is going on in your body. And out of the 1,000 mutations that a cancer cell is going to have, only 2 to 7 of those genes are actually required for a cell to become a cancer cell and to grow despite all mechanisms of regulation and all drugs that we're giving. We call those genes mostly oncogenes. I don't really think this is a term you need to remember, but basically know that although we're going to find a lot of mutations when we're going to look at the DNA of the tumor cells, only a very small fraction of those mutations are really critical to the tumor cells. And those are the ones that I put in red. And the orange ones are just a variety of different mutations that are here, but aren't as critical for the tumor cell to continue to grow. So once we have a drug that targets one of those 2 to 7 required essential red mutations, if we give a drug that specifically targets or cuts down or blocks the mechanism of those required genes, then most tumor cells will die. And this is usually a very effective mechanism for tumor cells to die and to get very good control of cancer cells. Once we have a drug that targets one of those other orange mutations, while it may affect overall the fact that the tumor cells might grow a little slower or some of them may die, unfortunately, when we're targeting those other passenger mutations that aren't as critical, usually the tumor cells, although they're going to maybe grow slower, maybe slightly decrease in size for a few weeks, eventually most of the tumor cells are going to survive and adapt to the drug and find resistance mechanisms. And then unfortunately, what we have for most cases in the mutations that we found in sarcomas is that we actually don't have any drug available at the time being. Although the number of drugs being developed to target very different types of DNA mutations is growing, and we have a lot of drugs in the pipeline in clinical trials investigating a lot of different mutation types. But as of right now, I would say, unfortunately, we are in the majority of cases, we are here. We're very good at finding all those little mutations, but we're not very good at having a drug to actually target them. So basically, what we call targeted therapy is whether we're targeting both the essential ones or the non-essential ones, which are also still going to slow down the growth of the tumor, but unlikely to cause tumor cells to completely die. So now moving really into sarcomas with those general concepts in mind. When we look at sarcomas in general, as I said, usually we have 2 to 7 mutations that are critical. And sarcomas on average have 4 mutations. When you look on average at all sarcomas, now subtypes of sarcomas will have more, some subtypes of sarcomas actually have less. But all sarcomas in general have 4 mutations in genes that are really important for tumor cells to survive. Here on the left, you have the name of the most frequent genes that are usually altered in sarcomas, the biggest one being TP53. The thing about TP53 is that as of right now, we really don't have any drug targeting this. There are a couple of drugs for specific mutations that are under development, and we're hoping that will lead to great responses, because this is definitely the most frequent alteration that we see in our patients with sarcomas. Sorry, excuse me. And then we have gene alterations in all those other genes, and I'm not going to go through all of them, but basically most of those actually do not have efficient drugs to target them right now. So when we look at the general sarcoma population, 40% of our patients, when we're going to look at all the DNA testing, in 40% of our patients, we're going to find at least one mutation for which we actually have a drug. Now, most of the time, those patients for whom we have a drug in sarcomas are the targeting the genes that are non-essential. Unfortunately, most of the drugs we have that can target alterations in sarcomas are for those orange one out of those thousands of mutations we see in the cancer cell that are non-essential, and to which the tumor cells usually can adapt. It will slow down their growth, so it's still worth doing, but it is unfortunately usually not able to fully cure our patients or bring significant benefit. So we're really looking into developing more drugs for those mutations that we think are more critical. Now, looking at this into a little bit more numbers, so those are different types of studies that have looked exactly at this question, looking at big cohorts of patients with sarcomas, specifically mostly soft tissue sarcomas, but some of them have bone sarcomas. All patients were having some genomic testing, so some DNA and or some RNA testing, which are similar things, and looking at how many of those sarcoma patients we were able to treat based on those mutations. So as you can see in this whole table of studies that is summarizing most of the sarcoma studies looking at this, the two biggest studies with big cohorts of patients here, both of them showed that 40% of patients, which is what I was saying earlier, actually have at least one alteration that we are able to give a drug to. One of those studies did not have any data about the treatment that was given or not given based on those alterations that were found. And then in this bigger one from the Memorial Sloan Kettering group, only a few out of this big series of patients actually had some clinical information for us to know about, and out of those 107 patients with some clinical information, only 30% of patients were eventually enrolled on clinical trials based on those results. Now, looking at all our other smaller studies, but still including roughly 100 patients in each of those studies, what we do find is consistently, basically, patients have between 30% to 60% of our patients, when we do genomic testing, we're able to find a mutation for which we will have a specific drug. Now, the big problem is that in all of our studies, what we mostly see is that although we're seeing 40% of patients can potentially get a drug based on this, only 4, 16, 13%, so 10-ish percent, 10 to 15% of patients eventually get a drug based on this. And what we don't know yet is why there is such a gap between the fact that we're seeing 40 to maybe 60% of patients being potentially eligible for targeted drugs and such a low number of patients eventually getting them. Now, when we actually give those drugs, here we have two of those studies, but this is going to be a very small number of patients, because 13% of 114 and 16% of 102 patients. But what we do see is that 25% to 50% of our patients in whom we do give those targeted drugs actually do have some form of clinical benefit from those drugs. So 25 to 50% of clinical benefit in our patients is really not negligible, especially after having treated patients with sarcoma that have metastatic disease or things that are more aggressive. 25 to 50% of clinical benefit is definitely something we need to look at in more detail. So the most recent study that's been looking at that is a French sarcoma group study. This is a very complicated graph. All it's meant to show is that patients in this study had all advanced soft tissue sarcomas, and patients were randomized, meaning half of them had the treatment, the other one didn't have the treatment, to actually have some next generation sequencing, which is the molecular genomic sequencing, or not having the genomic sequencing. If those patients had the genomic sequencing, then if they had a targetable alteration in their DNA, they were treated with a targeted drug, or if they didn't, then they weren't treated with a targeted drug. In those patients who were randomized to not getting the genomic sequencing firsthand, if they had treatment with a chemotherapy and it didn't work, then they were eligible to what we call a crossover. So eventually they could get the genomic sequencing and enter the other arm of treatment. So this is actually a quite big study that was done prospectively and with the most recent technologies. And the reason I'm trying to show this is because all the previous series, we were more around 40% of alterations that were potentially targetable. But now with newer technologies and newer development pipelines with new drugs, what we see here is that both in the arm that had genomic sequencing straight ahead, or those patients who had genomic sequencing after chemotherapy, basically what you see is 60-ish%, 58.6% and 57% of patients, 60% of patients ended up having an alteration that was potentially targetable based on the genomic sequencing. Now, some of the things we do have, I want to express a word of caution about is that when you look at the number of patients for whom, when we use their biopsy, the tissue of their biopsy or of their surgeries in order to look at the DNA or the RNA, as you can see, only 85% for the RNA and 70% for the DNA of patients actually had a contributive analysis. So this is something we definitely do have to take into account, is that our methods right now do need a lot of tissue and some good quality tissue for us to actually be able to give results on, is there a targetable or not alteration for our patients. And then this is the results of the whole trial are not shared yet. We'll be excited to see those results. This is an ongoing thing back in France. But what they did show is the different orientations that each patient's had to several different types of clinical trials matched on their genomic profiling. And so what you can see is that, once again, depending on the orientation, here you had like 40% of patients. So the total of this will be 60% of patients. But here you had 40% of patients recommended to that specific study. But in the end, only 13% of patients actually got that treatment. And I think we don't understand fully right now in the sarcoma field why we always have such a big gap between how many patients could potentially have those targeted therapies and how many patients eventually get on those clinical trials. And that may also be that some of those targeted therapies, what I'll discuss later on with some specific examples, some of them actually, because they're targeting those less essential genes, those 1,000 mutations that I played in orange previously, are not as effective as chemotherapies, unfortunately. So even though we have that option as clinicians, we still feel like chemotherapy will be more helpful to our patients. So just to try to show, and this is where I'm going to have, I think, 2 or 3 slides that actually have some scientific graphs. And I apologize for those of you who really aren't interested in looking at scientific graphs, but I did think that I would put a few graphs in it for those people who are interested in that. So this was a study where we looked at 214 patients who were treated on clinical trials and early phase clinical trials. So patients with very advanced disease in whom we usually don't have a good option. And the response rate all over the whole clinical trial spectrum was around 10%, which isn't great. Once again, those were mostly patients with very advanced disease. Some of the things we showed is one, that in some subtypes of sarcomas for which even chemotherapy hasn't proven to really be effective, it's okay and it's reasonable to give early phase clinical trials to our patients. As you saw here, this is where I'm going to have to explain a little bit those graphs, but this is what we call, those are what we call survival curves. So basically on the y-axis, this vertical axis, we're going to have the percentage of patients who are remaining without progression on the treatment. And on the x-axis here, the horizontal axis is time. So what we see is that this reddish line shows that patients who are enrolled in the first line setting, actually, there are more of them who remain without any progression after 1 year, 1.5 years, or even 2 years while they're on the clinical trial. So if you are treated on a first line clinical trial, if patients who are selected really based on the biology of things, they can have a very prolonged, those are all metastatic patients for which we don't have any standard of care treatment. They can have prolonged benefit. Then patients with second line treatment actually have usually less benefit, and patients with treated beyond the third line setting on early phase clinical trials have even less benefit. So what we showed is that by selecting our patients, sometimes patients going to early phase clinical trials earlier on in their treatment can benefit from this. But the important part of what we really showed was that this is the same type of graph, but this time we're changing the colors. So what we showed is that here the blue color is patients who were put on trial based on their specific histology, and the red line is patients who were put on trial based only on the molecular genomic profile, regardless of the histology, and the green line is patients for whom we put them on clinical trials regardless of the histology or of the molecular profile. And what this graph is trying to show is that patients who were put on trials based on their specific subtype of sarcoma or based on the molecular profile actually stayed longer on the drugs. They had more benefit of the drugs than patients who were treated regardless of the molecular profile or regardless of their histology. And this is another study led at Anderson looking specifically at what we call ultra-rare sarcomas here. So those are very rare subtypes of entities of sarcomas. And here, once again, so the curves, what they're showing, the green curve is showing patients that were put on clinical trials in patients with ultra-rare sarcomas based on the fact that their molecular profile showed a specific alteration in the DNA for which we had a drug, versus those patients who were enrolled on clinical trials without taking into account the DNA profiling. And what you can see is that those patients in green, some of them had prolonged disease control, were on clinical trials for up to 2 or even 3 years here. And those patients that had prolonged disease control were mostly enrolled in the trials that were looking at the molecular profile. And this is put here in numbers. And what we're seeing is that in patients who with ultra-rare sarcomas were enrolled in trials for which we matched the drug to the DNA profile, we had 24% of objective response rate and 36% of clinical benefit. And those who were on all-comer type of trials, not based on their DNA profiling, the objective response rate was only around 8%, and the clinical benefit was 26%. Now, once again, we're seeing this 25 to 50% clinical benefit rate, and probably improved with matched treatments. Of course, we would like to do better than 36% of clinical benefit rate. Those are usually patients that are heavily pretreated or for whom we have no standard of care in those early phase trials, trying to obviously do better than this. So I'm done with my complicated graphs. For the first part, what I really wanted to share with you is that I think personalized treatment for patients with cancer means finding a precise drug to kill tumor cells based on extensive testing, which includes the DNA and the RNA testing, other molecular tests, but also the clinical exam. The pathology is so critical, and the imaging. We're also needing to take into account each patient's other long-term diseases in the treatments that we get. Now, looking specifically at the molecular genomic testing, which a lot of you probably have heard about if you have more advanced disease. On average, 40 to up to 60% of tumors, sarcomas, will have an alteration for which we actually have a specific drug, but only a few patients actually receive this drug. And then the clinical benefit that we get from this drug is estimated to be around 25 to 50%. Now, once again, the vast majority of those 40 to 60% of alterations are usually not the red essential genes that the tumor cells are really relying on in order to survive. It's mostly targeting genes that are passengers that are here that are helping the tumor cell to grow, but not as critically. So now I'm just going to try to use 3 examples in order to show what I'm meaning with all of this. So when we're looking at GISTs, It's this one of the most frequent types of sarcomas, which is gastrointestinal stromal tumors. In 75% of those tumors, we actually have KIT mutations. And this is the vast 75% of those tumors, so the vast majority of those tumors. And in 2001, as you can see, this made the cover of Time magazine because we found a specific pill, which the name is Gleevec, that is extremely effective against KIT mutations, and that clearly revolutionized the prognosis and the treatment of patients with GISTs in this specific subtype of sarcoma. When we look at the treatment of GIST today, we went even deeper, so we can look at the subtypes of exact mutations, and when we give Gleevec to patients with subtypes of mutations, what you can see is if we have this first subtype of mutation, we have 71% of response rate, versus if we have this other subtype of mutation, it's lower. But if we increase the dose, it actually goes back to very close to what it was. Now, as you saw on the previous slide here, we also have those 25% of patients who actually have other mutations, and we now can know in those patients who have other mutations, what's the response rate to that imatinib, that Gleevec, that cancer pill that made it to Time magazine, and it's not the same. Now, I'm not going to enter too much details, but today we actually have for GISTs specific drugs targeting other mutations. So for that specific PDGFR alpha D842V mutation, we now actually have a drug that is very effective. We're now in this very subtype of tumor, in the vast majority of cases, we're now able to have very specific drugs that work. And those response rates are around 70 to 80%. And that's because we're targeting very critical genes in the cell, and that's those red genes. And so that's one of the poster child examples of we are able in this particular case to look specifically at the genomic sequencing, and we have a drug and it works. Another example of that is more recent is the NTRK, NTRK. And here is another type of graph, and I did want to show you both the survival curves and those plots that are called waterfall plots. I know it's a bit complex sometimes, but those are the two most frequent ones for those of you who like to read scientific articles. So what this graph shows is each one of those bars is a patient's tumor, and then it's looking at how much the tumor grew or shrunk with the treatment. So this is 0, and this is minus 100%. So all of those 5 patients here on the specific drug that was targeting this specific NTRK mutation, patients had 100% of their tumor shrink, meaning the tumor disappeared. It's what we call a complete response. But all of those other bars going down from 0 here represent patients who have had a decrease in their tumor size, probably here around 90%, here around 80%, 60%. 60% is actually around here. So as you see, the vast majority of patients on those drugs here, are having decrease in size of their tumors. And that's because in this very specific translocation, genomic alteration in this specific gene, which is NTRK, we now have drugs that are extremely effective. And that's because this is one of those 4 essential genes that really the tumor cell needs critically in order to continue to grow. And that's where we see those 80% clinical benefit. And those are 2 different drugs that have been developed with the same type of mechanism of action. But what you can see is that, yes, those drugs, when we're targeting exactly a critical mutation and we have a good drug, then it actually works. Now, I want to show you example of a more complicated story, which is the dedifferentiated liposarcomas. So dedifferentiated liposarcomas are one of our most frequent soft tissue sarcomas, and they usually have amplification, so alterations in 2 genes. One is MDM2 and the other one is CDK4. And we actually have drugs for both of those alterations. So when we're looking at the CDK4 inhibitors, so the drugs that would target specifically the CDK4 alteration, they have limited efficacy. So at least one of them has limited efficacy, the palbociclib. It does somewhat slow down the growth of the disease, but usually not for a long time. We're now having a trial for which we're going to wait for the result pretty soon of abemaciclib, which is a more potent CDK4 inhibitor. Results are awaited very soon from a big trial of this CDK4 inhibitor. What we think is this abemaciclib is probably very helpful, but probably only in somewhat 20% of our patients. And so, as I said, in those tumors, we have CDK4 and we also have MDM2, and both of those genes are altered. And when we look at MDM2 inhibitors, which are currently under development in trials, same thing. We're having some patients who are having some benefit of it. It's going to be around 20% response rate. But it's not going to be the 80% that we're seeing when we're looking at those GISTs with the KIT mutation or those NTRK alterations with those two drugs and those waterfall plots that we were talking about. So what is currently under development with maybe a promising approach, if the combination is tolerable, is to actually combine and target those two things, because maybe both of them are actually critical to the tumor cells. Now, this is under development in some clinical trials. I don't think they're opened yet, but this is something that has been in the back of our minds. One of the biggest problem is that when you give two drugs together, you're going to have more toxicity, and that has been a major challenge in developing those combinations. What I did want to show with the example of dedifferentiated liposarcomas is sometimes we actually have a drug, we know the alteration is there, we have a drug, but if it's not the only critical gene, then yes, some of our patients are going to benefit from it, but it's not going to be as great as the NTRK mutations or the GIST that we just discussed before. So before I conclude, I have two kind of small slides with some conclusions and some thoughts. So the first thing is, why would you do the genomic DNA testing? So first is to identify very rare targets, because yes, 40 to 60% of our patients do have some targets, but those that are really helpful and powerful targets within the sarcoma field are very rare. The NTRK alterations that we're talking about concern less than 1% of our patients, unfortunately, and those DNA alterations that are really benefiting from drugs remain rare. So this is somewhat of a fishing expedition. However, this will also give you access to the clinical trials and the most novel drugs. And as I was saying, we currently have a lot of drugs in the pipeline trying to target very aggressive diseases that have mutations in genes that are very critical. So if you want to have access to those clinical trials and those novel drugs, we actually need to find the alteration in the DNA of your tumor cell. And then one of the reasons to do this, as always, is actually to improve knowledge for other patients, because a lot of the genomic testing, your physicians can use it in different studies to look at what is the percentage of patient with sarcomas who have that genomic alteration or not. So why shouldn't you participate if you do not have insurance coverage for those genomic testing? The cost is prohibitive. When we do it, so we only do it in patients who have disease that has spread or that is relapsing in what we call the advanced disease setting. So why we don't do it in the localized setting, it's because surgery is the treatment. Surgery and chemotherapy has proven to be more effective when chemo is needed in the localized setting than any of those targeted DNA drugs. Usually the first line of therapy, even in the metastatic spread or relapse setting, will still be chemotherapy, because that's the type of treatment for which we have the best efficacy data. But after the second line, after we're finished doing the chemotherapy, if the tumor's not responding or is progressing despite this chemotherapy, then really that's when being treated with those targeted drugs is really helpful. Now, what I usually do in my practice is I actually send the DNA testing even before starting the chemo. I just start the chemo and send the DNA testing at the same time, just because those results can take 4 to 8 weeks to come in. As we discussed on one of the slides, we do have 20-ish% of patients for which the results are not conclusive. And so if I send things very early on, even while I'm treating my patient with chemotherapy, then if the results are not conclusive, I have time to maybe redo a biopsy if needed, in order to obtain those results, so that if chemotherapy fails, I actually already have those results and I can treat the patients according to those results. So I usually do it exactly when my patients have an indication, meaning once, unfortunately, if the disease has relapsed, or if the disease is metastatic, or if we just cannot operate on the disease. So as I said, I would not do it in localized diseases. So what type of genomic testing? Because you're going to hear of a lot of different companies doing a lot of different genomic testing. Honestly, they're all equivalent. Usually some centers work better with some people because they're just used to working with that provider. Um, I I think all of the companies are very similar, and I wouldn't advocate for one being better than the other. Okay, so about personalized medicine and targeted therapies, what would I think you would need to ask your oncologist and when to ask it? So if you have not been told that you had an indication for genomic testing, and you have a disease that is advanced, I would talk about it with your doctor right now. Just ask him if he or she feels like genomic testing would be useful. And then once there's actually a mutation identified, I would ask my doctor if there is an available targeted drug for this particular molecular alteration. If the drug is as accessible as standard of care, or if it needs to be part of a clinical trial, as most of those are currently only part of clinical trials. Is the drug more effective than chemotherapy for this particular molecular alteration? As you saw, some of those alterations, when we give a drug, it's super effective, and others, there's some benefit in some patients, but it's unclear that it's a long benefit. Then very important is, what is the toxicity and the benefit that your doctor is expecting from the drug? Those are all my collaborators at MD Anderson that I'm very, very fortunate to work with. And I will take questions.